true, and also it is important to understand the differences as well. So when we talk about the lung diseases, there are diseases of the airways, that is the breathing tubes, and the diseases of the parenchyma. Now, both asthma and COPD, COPD stand for chronic obstructive pulmonary disease. Both of these are diseases of the airway that you already know. And they are called obstructive airway diseases because the main problem is that there is narrowing or obstruction to the airways, breathing tubes, and because of that, there's a limitation of the airflow. So both asthma and COPD are obstructive airway diseases. So if you take asthma, what is asthma? If you are asked to define what asthma is, it is a chronic inflammatory condition of the airways. So there is an inflammation there, and in the foundation module, the pathology, you have learned about the inflammation, the meaning of the word. Because of this chronic inflammation of the airways, there's obstruction to the airway, so narrowing of the airway, which is variable and reversible. What it means is not same every day or every time the same day. It varies and it can be reversed sometimes with medication and sometimes even spontaneously. Another consequence of this inflammation is that it leaves the inner lining or the mucosa of the bronchi hyperreactive. When they are hyperreactive, they can respond to any environmental triggers very quickly and in a serious manner. So there's an inflammatory condition. The result of the inflammation is twofold. One is there's airway obstruction, which is variable and reversible. And the other one is that it leaves some kind of bronchial hyperreactivity, increased bronchial reactivity. So the bronchial mucosa and the bronchi are extremely sensitive to any environmental triggers. So these are the keywords. Therefore, inflammatory, obstruction, variable and reversible, and there is hyperreactivity. So what is COPD? COPD is also an obstructive airway disease. This disease is also characterized by airflow limitation or bronchial narrowing. But unlike asthma, it is not fully reversible. In asthma, it is reversible. And also, the airflow limitation is progressive and also associated with an abnormal inflammatory response of the lungs to gases or noxious particles. So the similarity between COPD and asthma, as you would have noticed, is both are inflammatory conditions of the airways, though there are some differences in the inflammation. Both cause airway narrowing or what we call airflow limitation. The difference is in asthma, it is reversible and variable, whereas in COPD, this is not fully reversible. So those are the difference. We'll go into details about COPD when we talk about the COPD. Now you have had lectures, pathology lectures, asthma and COPD, and you have learned about the inflammation and what causes these airway narrowing. So this is what I mentioned, the COPD. I'll be revisiting this when I come to the COPD lecture. So obstructive airway disease, there's a COPD and there's asthma. But sometimes clinically, there's an overlap between the two. So clinically, the patient, sometimes we cannot give a clear label whether this is asthma or COPD. So as you see, there's a bit of overlap here. This is called nowadays asthma COPD overlap syndrome. So these are the patients whom we cannot clearly categorize as whether they belong to COPD group or to asthma group, because they have some similarity of clinical features of asthma and some of the clinical features of COPD. So let's briefly look at the pathogenesis of asthma. I'm not going into details because you have learned this in your pathology. One of the things that causes symptoms in asthma is this airflow limitation. What causes airflow limitation is, as we mentioned, there's inflammation in the airways. Because of this inflammation, there is airway hyperresponsiveness or airway hyperreactivity, and it responds to variety of stimuli in the environment, what we call triggers. They are either direct stimuli like allergens, allergic substances, or some indirect stimuli. So there's inflammation, it's causing airflow, airway hyperresponsiveness. When it is subject to some triggers which can be either allergens or indirect stimuli, there's airflow limitation and the production of clinical symptoms. So asthma is chronic airflow limit airway inflammatory disease, and these symptoms are, there are four main symptoms. Those are the wheeze, cough. This cough is usually a dry cough with production not much of sputum coming up, mostly at night and early in the morning. Other important symptom is shortness of breath or dyspnea or breathlessness, and a feeling of chest tightness. This feeling of chest tightness is because there is narrowing of the airways or breathing tubes. There's trapping of air inside the chest. Because of this air trapping, there's a hyperinflation. The lungs get hyperinflated and the patients feel it as some kind of chest tightness. So there are four symptoms of asthma: wheeze, cough, breathlessness, and tightness of the chest. Another very important characteristic of these symptoms is that the symptoms, they vary over time in intensity, because I understand that airflow limitation also is a variable from day to day and even within the same day. So this airflow limitation, it varies over time in intensity. Because of that, these symptoms also vary in time. So the patient's symptoms, some days they feel better, and some days they feel very symptomatic. Even within the same day, in the middle of the night or early in the morning, they might feel these symptoms, but during the daytime, they might feel all right. These symptoms and airflow limitation may resolve spontaneously or in response to medication. When you give correct medication, they feel better, the symptoms disappear. Also, sometimes without any medicines, also they feel better because there is a spontaneous resolution of the symptoms, which we call a remission. So, asthma is a chronic disease, it's an inflammatory disease, and there are remissions and exacerbations. Remissions are what we mean by the periods are symptom-free periods. They feel better either with the medication or spontaneously. Sometimes they get exacerbations or worsening or flare-ups because their hyperreactive bronchi are triggered by variety of indirect and direct stimuli. What are these stimuli, the triggers? We will come to that in a minute. But often these are the triggers, that's exercise, various allergens, Irritants, sometimes change in the weather, and also viral respiratory infection. It's very important to recognize these triggers. When you take a history from the patient, you ask about things that make his asthma worse, the triggers, because one of the management steps is to avoid the triggers. Can you all still hear me? Are you all with me? If you can't hear or anything, just write in the chat box or uh, just unmute your microphones and come back. Okay. This you have already gone through in your path. There's a mediators, release of mediators. There's inflammation, which is causing airway hyperresponsiveness, airway obstruction, causing clinical symptoms. There are a variety of mediators, again discussed in your path lecture, particularly cytokines, interleukins, and tumor necrosis factor, TNF, are important in the pathogenesis of this inflammation. Triggers, sometimes you can recognize, sometimes you cannot recognize a trigger. And this is called intrinsic. When the asthma is not caused by anything outside, we call it intrinsic asthma. There's the release of mediators, there's inflammation, and the result of inflammation is 3 or 4-fold. There's a contraction of the smooth muscles, there's edema of the mucosa, there's a secretion or in fact hypersecretion of the mucus, and there is increased sensitivity of the bronchial inner lining or mucosa. So the result of these three, that is smooth muscle contraction, mucosal edema, and hypersecretion of the mucus, is narrowing of the airflow. When the airflow is narrowed, the airways are narrowed. When the airflow is limited, there's increased resistance to breathing and it causes breathlessness. Just to recap the path lecture you have had. Example of bronchial mucosa in case of severe asthma, showing narrowing and edema of the mucosa. Right. So let's get back to the triggers, because clinically when we encounter patients, we need to find out what triggers asthma in order to avoid these things. Yeah, one of the commonest triggers is upper respiratory tract infection. Usually they are viral upper respiratory tract infection. We get a nose cold or sore throat. Next moment, it goes into the chest and you get an asthma exacerbation. So avoiding viral infections are important. Now, these days after COVID, most of the people are wearing masks, and also they are careful about overcrowding, keeping distance, and washing hands. So there's a significant reduction of the viral upper respiratory tract infection. As a result of that, even asthma exacerbations are less these days, simply because of the prevention of viral upper respiratory tract infection because of the respiratory hygiene methods. Another trigger is variety of irritants. What are these irritants? Tobacco smoke or cigarette smoking, cooking fumes, pollutants in the environment, particularly people who are working outside on the road, like policemen, road workers, and others, which is a risk, environmental pollutants, and in certain occupations. So therefore, it's very important to get a good occupational history in these patients, asking about the exposure to wood dust. that is carpenters, grain dust, people who have rice mills and grinding mills, flour and other things like boutique owners, wholesale market, people who work in wholesale markets selling uh, things like rice, dal, and flour. Tea dust exposure, people who work in tea factories. So these are the occupations who are at risk for the increased asthma exacerbations. So take a good history, ask about these things. Allergens. Inhaled allergens, particularly pets, if you have pets like dogs and cats, birds, pigeons. There are people who have pigeons as a hobby, and sometimes even without the hobby, in old houses and all, pigeons occupy the ceiling space, like in the lecture hall A in the medical faculty. There was time there was a lot of pigeons there. Mold is a fungi on the walls. When the walls are wet, you can see the fungi, and the fungi spores you can develop hypersensitivity and can act as an allergen. When cockroaches, though you don't keep them as pets, they can be there in the houses. Another group of allergens are ingested ones. Food allergies, if the patient can recognize that certain food items make asthma worse, important to avoid those things, particularly certain preservatives and coloring used in food preparations. And another important thing to ask, if particularly if the asthma is not getting better, is about using hair dye. People sometimes they have been using the hair dye for a long time, but even then they can become hypersensitive. So without your knowledge, hair dye may be the offending agent. Drugs, medications, ask about aspirin, NSAIDs, and the beta blockers like propranolol given for high blood pressure and cardiac problems. People with sinusitis or chronic rhinitis, allergic rhinitis and rhinosinusitis, it can act as a worsening factor for asthma. Those who have gastroesophageal reflux, people with when the uh, the esophageal gastroesophageal sphincter is not working properly, and also very obese people and those who are taking any medication that might cause gastroesophageal reflux, acid reflux can trigger asthma attacks. So you need to ask about symptoms of gastroesophageal reflux like heartburn, acid coming up into the mouth, burping type of thing, belching. But even without symptoms, sometimes one can get gastroesophageal reflux causing triggering asthma attacks. Exercise is another factor in the minority in some individuals is called exercise-induced asthma, particularly if you exercise in cold weather, early in the morning, cold weather, can get asthma attacks after exercise. This does not mean that exercise is bad for people of asthma. Exercise should be encouraged, which is in a smaller percentage of patients with asthma. Exercise can trigger asthma attacks, particularly if they breathe cold air. And emotions are also well known to trigger asthma attacks. Let me see what has gone wrong with the. Okay, coming back to presentation. Coming back to the presentation. Okay. Clinical picture of asthma is the patient presents with these four symptoms that I described earlier. Wheezing. Why do they get wheezing? Because there's airway narrowing. When the air is pushed out, you get this rhonchi, the noise coming, and it is particularly an expiratory noise. Wheeze is an expiratory noise which you hear on both sides of the lungs. They are breathless. Why are they short of breath? They need extra effort to push air in and out of these breathing tubes because of the increased airway resistance. They have chest tightness. Why have they got chest tightness? Because of the airway narrowing. There's air trapping inside the lungs and there is hyperinflation. That's why they get chest tightness. And coughing, because the hyperreactivity of the bronchial mucosa and there's a mucus, increased mucus secretion, increased sensitivity, and there's a stimulation of cough receptors. So these are the four main symptoms: wheezing, breathlessness, chest tightness, and coughing. And they come in episodes or recurrent episodes. They are particularly at night or early in the morning. And usually they have one or more symptoms, these, not just one. Because of the variable airflow obstruction, it's reversible either spontaneously or with treatment. So they feel better at times, they feel bad at certain days. They say then they take the medication, they might feel better. The next day or again, it can come back. So that is the variability of these symptoms. Excuse me. The physical examination, I think important lesson here, important message I want to tell you is do not rely on physical signs to diagnose asthma or COPD. The reason is the chest can be normal because it's a variable disease. There are good days and bad days. On a good day, the chest can be normal. The classical physical sign is a bilateral rhonchi. What causes rhonchi? There is a narrowing of the airflow when it travels through that, and this causes some kind of turbulence, and this produces rhonchi. Rhonchi and wheezes are the same thing. It's a musical sound that is produced, particularly during expiration. Breathing noises you get in inspiration called stridor, and it is usually produced in the upper airway, the larynx, and in the upper airway. Bronchi are produced in the lower airways, and during expiration, the bronchial diameters get even smaller, they get even more narrower, and that is why these rhonchi are more during expiration. The expiration, as you know, bronchial diameters are smaller than during inspiration. Crepitations are not a feature unless there is superadded infection. And during a very severe attack, the airway narrowing is so severe that there is any air movement in and out of the breathing tubes, and in the chest may even be silent. So remember, during a severe attack, there may not be any rhonchi, and chest may be just silent when you auscultate. And the other features of respiratory failure or respiratory difficulty may be present during an acute attack like tachycardia, tachypnea, cyanosis, and like that, but not during the normal times. But the differential diagnosis of asthma I'm not going to discuss here because this is not the clinical sciences stream lecture. This is in the applied sciences, and this doesn't come in the scope of this lecture. But briefly, I must tell you about how to diagnose asthma. Initial step in the diagnosis of asthma is to suspect asthma, that is on clinical features. What are the clinical features? Mentioned already: cough, breathlessness, wheeze, and the chest tightness. And they have a characteristic pattern being there's a variability. They are usually more at night or early in the morning. And usually they have more than one or more symptoms, and the variability of intensity over time. They are not progressive, it's variable. There are remissions and exacerbations, good days and bad days. And the exclusion of other things in the differential diagnosis. There are many clinical conditions that might mimic asthma, called mimickers of asthma, that might look like asthma. Those things you need to rule out in the clinical examination. And having suspected that on the history and the physical examination, second step is to objectively confirm that. How do you objectively confirm? That also comes in two steps. As you already know, asthma is a obstructive airway disease, so you have to prove, you have to show objectively that there is airflow limitation, and this airflow limitation is reversible. That's a second step to show that this is a reversible airflow limitation. So some of the equipment that we use for this is one is a peak flow meter. This measures the peak expiratory flow rate. It's given in liters per minute. It's a simple thing that you can do bedside. It's very useful to monitor peak flow rate throughout the day. If you do 4 or 5 times a day, you will realize early in the morning you get the lowest figures, and as the day go on during daytime, it improves. And if you measure this daily for a long period of time, again you will see the variability. When the patient is about to get asthma exacerbation, you can see a dip or gradual fall in the peak flow meter readings. So this is a very useful thing. Another equipment that we use is a spirometry. We have done in physiology. Spirometry measures the FEV1 and FVC, forced expiratory volume in the first second, and forced vital capacity or vital capacity, and one can calculate the FEV1 or over vital capacity ratio. So to confirm that there is obstructive airway disease, one has to show that the FEV1 over VC ratio is 70% or less. That shows that there is a obstructive airway disease. So criteria for obstructive airway disease is the FEV1 over vital capacity ratio is 70 or more. To assess the reversibility, what we do is we give a bronchodilator. We've had a pharmacology lecture. You know some of the examples of bronchodilator medication. One example is salbutamol. You give a salbutamol inhalation and you recheck the FEV1 to see whether there is an improvement in the FEV1. If there is an improvement in the FEV1 after the bronchodilator, then we know that there is a reversibility. So there are certain criteria to define the reversibility. Don't worry about that. Just to know the principle, not the exact numbers. There are certain other investigations that we need to do because in the differential diagnosis, you need to rule out some of the things. They are the chest X-ray, white cell count to show that whether there's any neutrophilic leukocytosis. You want to know whether there's infection. X-ray is important to rule out other conditions that might mimic asthma, such as tuberculosis. And the peak flow rate, as I mentioned, useful to monitor the disease, to assess the response to medication, and sometimes is useful in the diagnosis of occupational asthma, because if you monitor the continuously with the peak flow rate every day, when the patient is working at work and the patient is out of work, And if there is a drop in the peak flow rate when he is working in the factory, then we know that his asthma may be related to the job he is doing. So it's useful in that way also to confirm the relationship with work, to monitor while at work and off work. Let's look at the having understood what caused the asthma and the pathogenesis, its clinical symptoms. Let's look at the principles of the treatment. To understand the principle of treatment, that we need to understand the pathogenesis, which you already know, that only some people get asthma, so there's a genetic susceptibility, particularly the people who have a family history are prone to get asthma. It doesn't mean that if your parents has asthma, you will invariably get asthma, or if your parents do not have asthma, that you are not never going to get asthma. No, it's not like that. But there's a genetic susceptibility. There's nothing you can do about that at present. There are no medication to remove or to erase or delete this genetic susceptibility. The genetic susceptibility, because of that, when the patient is faced with triggers, when they are exposed to triggers, there's a release of variety of mediators, and that causes inflammation. And the result of the inflammation is the obstruction of the airway, edema of the mucosa, hypersecretion of the mucus, and bronchial hyperreactivity. So our treatment, therefore, is designed to attack this diagram at different stages. So we might be able to attack at this stage or inflammation, or may be able to counteract the release of the mediators. Of course, if you can identify the triggers, you can avoid exposure to triggers as much as possible. But here, there's nothing at present we can do. The genetic susceptibility. So what are the things, what are the armaments or the weapons we have against this to avoid the triggers? We have drugs that can inhibit the mediators, release of mediators. We have anti-inflammatory medications to counteract inflammation. It's one of the cornerstones in the management of asthma. Is these anti-inflammatory medications, ideally delivered directly to bronchial mucosa through the inhaler route, and the results of inflammation like airway obstruction we can counteract with the use of bronchodilator. So these are the weapons we have in our armament to counteract this cascade or this process and to give some relief to the patients with asthma. Avoid allergens. We have drugs to influence the bronchial muscle tones. You already know that these are the sympathetic drugs, agonists like beta receptor agonist and anticholinergics that counteracts the parasympathetic tone. So you either augment the sympathetic tone with beta receptor agonist, beta agonist, or you inhibit the parasympathetic tone with anticholinergic. Then we have xanthines. Xanthines are no longer used very much because of their adverse effects. Things it was used many years ago, but we are not very fond of xanthines now. Then to reduce the inflammation, we have steroids or glucocorticoids, steroids. And to counteract, inhibit the mediator release, we have chromoglycates and leukotriene receptor antagonists. To allergens, we educate the patients about living in a dust-free environment, molds, identify and reduce the allergens, food, inhale, and sometimes if there's heavy carpeting and curtains and all, you can get a little this house dust mite. This is more of a problem in the Western countries where there's heavy carpeting and curtains. This sort of the guy living there, and the patients can become hypersensitive to this trap, this house dust mite, and you need heavy cleaning of these things. Drugs to influence bronchial smooth muscle tone, beta 2 agonists, we have short acting ones and long acting ones. Short acting ones that are used are salbutamol and terbutaline. Long acting ones, long acting beta agonists are salmeterol and formoterol. These are available in as inhalers, dry powder inhalers, as well as the metered dose inhalers. Then we have xanthines. One of the commonly used ones is theophylline, again available as oral tablets or intravenous preparations. Again, as I mentioned earlier, we are not very fond of these things because of the adverse effect profile, and we prefer not to use these nowadays. Anticholinergics, again we have short-acting anticholinergics, ipratropium, available as inhaler, long-acting muscarinic and intermuscarinic agents, LAMA, or tiotropium. It's a long-acting drug available as once-a-day inhaler therapy. If you look at the drugs to counteract the inflammation, the glucocorticoids, inhaled ones are the ones that are preferred to oral ones, because as you know, long-acting, long-term use of oral glucocorticoids causes a lot of adverse effects like Cushing's syndrome, obesity, diabetes, osteoporosis, cataract in the eye, and other joint problems like avascular necrosis, electrolyte disturbance, myopathies, the muscle wasting, and things. Therefore, we prefer not to use systemic or oral glucocorticoids long term. Our preference is inhaled glucocorticoids, where the systemic adverse effects are much less and the delivery can be made directly to the mucosal bronchial mucosa, and the doses therefore can be much lower than the oral glucocorticoids. The three types are available: beclomethasone, budesonide, and fluticasone. These are available as inhalers. To mediate a release, we use leukotriene modifiers, there's a Montelukast, and the master stabilizer, an example, is sodium chromoglycate. This is used in pediatric practice, but not so much in adult practice. Montelukast, in addition to being a leukotriene mediator release modifier, has weak bronchodilator properties as well. So it is a bronchodilator as well as an anti-inflammatory in one way, and it is not available as an inhaler. It is given in tablet form as an oral medication. So they come in various shapes and sizes and colors, and they are color coded. We divide these bronchodilators, we call them relievers because there is immediate relief when bronchodilator is given, but they don't have any effect on long-term or anti-inflammatory properties. There are no anti-inflammatory properties. They are relievers and you can get an immediate relief. But because asthma is an inflammatory disease, this, one needs to give anti-inflammatory medications as well. So they are usually color-coded green or blue. Then when we take the anti-inflammatory medications, we call them preventers. Yes, you don't get an immediate effect because they are anti-inflammatory. They don't have any quick bronchodilator effects, and they are color-coded brown, orange, or this sort of a color, sometimes purple. Then we have combinations of these. Same inhaler carrying bronchodilator as well as anti-inflammatory preventer medications. They are different, they have other color coding, different color coding. So how do you manage a patient with asthma? What are the principles? There is principle of step care. What is meant by step care is we take it in steps like this. If the asthma is very mild, we use lower step, very mild medications. And as it gets worse, or if you are not getting control with simple medication in the step one, we try to go into higher step, the medication. If they are controlled, then we can achieve control, we try and see whether we can come down onto a lower step in the medication. So the medications, we don't give all the medications to all the patients with asthma. It depends on the severity. The mild cases, we try and use with very the lower kind of less powerful, if I may say, medications. But if the patient's asthma is not getting controlled even with the lower rung of medications, then we are forced to give 2 or 3 medications and sometimes higher doses. So this is what is meant by step care. To give an example of step care, very mild asthma, if they are getting very occasional symptoms, not daily symptoms, occasional, we try to use to uh, bronchodilator like a salbutamol terbutaline as SOS. As SOS means whenever you need it, like not on a regular basis, whenever you need it. Another term that is used is a PRN or SOS basis. And whenever they have symptoms, they can take salbutamol or terbutaline inhaler, 1 or 2 puffs. But if they are not controlled with that, if they need more medications, they or regular use of salbutamol or terbutaline, then we realize that we need to go to the second step and to add an anti-inflammatory medication. In this case, a steroid inhaler, usually a lower dose steroid inhaler as a regular medication. So that is second step. If the patient is not getting control even with that, then we need to look at step 3, 4, and 5. You will learn more about this in pharmacology. I just want to introduce you to the concept or the principle of this step care medication. So the step 1 and step 2, the patient is not, the asthma is not getting control. We have no option but to go into a high dose inhaled corticosteroid or add something like a long acting bronchodilator like a salmeterol or formoterol. Now we never give salmeterol or formoterol or long acting bronchodilator alone without a steroid in these early steps. Earlier step, we try to use with short-acting bronchodilator. If the patient needs that more regularly, then we go on to a low-dose steroid inhaler. If it's not getting controlled, we have to go into a high-dose steroid or combine a low-dose steroid with a long-acting bronchodilator. That's also not getting control, then we have to use a high dose inhaled corticosteroid with a long acting a bronchodilator or an anticholinergic like ibuprofen or tiotrope. So this is what is meant by uh, step care. There are some minority of patients who cannot be controlled with this. Then we have no option to look at the other immunosuppressive medication, and that is a job for the specialist. So having said this, nowadays there's a little change or little modification to step care in asthma, as people are recommending to use even low dose steroid even in very first step in asthma step care. Now earlier, first step of it says my internet connection is unstable. I hope you can still hear me out. Can you hear me? Hello.
Yes, sir, we can hear you.
Right. Okay. Thanks. Thank you. So earlier, the first step was always short-acting bronchodilator given whenever necessary. Now, having recognized that the asthma is an inflammatory condition and the importance of early use of inhaled glucocorticosteroids, newer guidelines recommend the use of low-dose glucocorticosteroids even in step one. So there is a little the change, little deviation to the previous practice in the current medication. Sometimes, in spite of proper treatment of asthma, they get asthma flare-ups or exacerbations. These exacerbations can occur due to a variety of reasons. The definition of exacerbations is the increase in symptoms or worsening of lung function from the basal status. That could be either just mild exacerbations or acute severe asthma or sometimes life-threatening asthma. Now, there are clinical criteria to define these various stages, like what the clinical criteria for acute severe asthma and clinical criteria for life-threatening asthma. I'm not going to go into details this one because this is not a clinical stream lecture. We'll learn about that later in your clinical appointments as well as when you come to the clinical sciences stream. But it's important to recognize what causes asthma. Sometimes external factors like viral upper respiratory infection or exposure to allergens. Most of the time, it is poor adherence to controlled drugs. When the asthma is controlled, the patients feel that they do not need to continue with medication, so they stop control of medication or prevented drugs or steroid medications, and they end up having an exacerbations. Sometimes, due to no apparent reason, cannot recognize a reason, and they go into exacerbations. Occasionally, as patients with asthma might present with severe exacerbation with no previous history of asthma, and it's difficult to make a diagnosis when that happens. So treating exacerbations, again I will go into the principles. They will need oxygen because they may be hypoxic. This is due to severe bronchospasm. They need inhaled short-acting beta agonist, and the best route in this situation is a nebulized route, either continuous or intermittent nebulization. If the nebulization is not available, now this is available in almost all hospitals, one can use metered dose inhaler with a spacer device, but the preferred device is nebulized route, which is available almost everywhere. Very important to give short courses of systemic glucocorticoids. Steroids, preferred drug is prednisolone oral dose. If they cannot take it orally, either maybe because of the vomiting or other reasons, then only inhaled route is used. That is given as an intravenous. they can take it orally or a prednisone. If you're not responding, you can use ipratropium as a nebulized ipratropium as an add-on treatment, and sometimes intravenous magnesium is used as a bronchodilator in this situation. The aminophylines, we try to avoid it, but sometimes there's no option. And occasionally, very rarely, we'll have to treat these patients in the intensive care unit. Sometimes they go into severe respiratory failure. One is respiratory support in intermittent positive pressure ventilation. So there are guidelines. I urge you to read the guidelines. There's management of asthma guidelines in the Sri Lanka Medical Association, and also there are guidelines. I have in your LMS. I have uploaded a link to asthma guidelines by the global initiative of asthma that's called GINA guidelines. I would ask you to look at this if possible. Okay, so this is where I stop, and if there are questions, you can ask questions in any chat box, and also in the LMS there's a forum, discussion forum. There are any questions, you can post the questions there. I would try to address them within the week, and that will be left open for a period for a week. If you have any questions now in your chat box, one or two questions, I'll be able to take it. If you can type it, or you can unmute your microphones and ask. This question is an age of onset for asthma. Asthma is usually considered a childhood illness. There are many people, but there's a late onset asthma as well. Some some of the people who get asthma in their childhood, they go into a remission, and later on, uh, they might never get asthma, or some of them in their adulthood they get asthma. And there is a minority of people they get asthma for the first time in their adulthood. Whereas if you look at COPD is it occurs in middle age or later life. So asthma, they can get childhood asthma, and some of them go into remission. Later on, also they can recur. Some patients get asthma for the first time as a late onset asthma. In any patient with asthma, it's important to ask for childhood history, the past history of asthma, also family history of asthma. Also in atopic things, the atopy is there are three conditions they get hand in hand. That is eczema, allergic rhinitis, and anything else? Any other questions? Okay, I'll stop here, and tomorrow I'll be yeah yeah okay. What are the complications of chronic asthma? Well, the biggest problem with asthma is exacerbations. These exacerbations can be fatal. During the exacerbations, they can go into uh, respiratory failure, and if not treated properly, they can even die. Apart from that, the other uh, complication as such is that because this is obstructive airway disease and there's hyperinflation of the lungs, if there are any bulli in the lungs, bulli are small air-filled cavities. If they are just underneath the pleura, they can rupture into the pleural cavity, can lead to pneumothorax. Those are the two main complications of asthma. Exacerbations due to infections, infective exacerbations might lead to respiratory failure. Other one is pneumothorax. Okay, I'll stop here and we'll meet you tomorrow, I think at the same time. Okay, bye.